Hello, everyone, and welcome to our webinar, Approaching End of Life, Signs and Symptoms. My name is Lauren King, and I'm the Community Education and Caregiver Academy Manager at Coastal Hospice. Among our attendees today, we are happy to see so many familiar organizations with us. We have colleagues from Tidal Health, Atlantic General Hospital, Encompass Health, Shore Regional Cancer Center, MAC Incorporated, Anchorage Healthcare, and many more. It's wonderful to see everyone today. Before we begin, allow me to go over a few housekeeping items. You may see myself or my colleagues, Alejandra and Joy, pop up in the chat box to address or help with any technical issues. I want to thank you for your patience ahead of time, should we have any. I will also come back at the end to discuss the program evaluation. We will be using the chat feature to communicate with you throughout the webinar. You can access it by clicking on the messaging icon in your meeting controls. Our webinar today will be moderated by Lauren Blair, Community Relations and Development Manager and Caregiver Academy Moderator at Coastal Hospice. Lauren has more than 15 years of experience in the healthcare field. She holds a master's degree in social work from Salisbury University, is a licensed master social worker in the state of Maryland, and a licensed clinical social worker in the state of Delaware. Lauren serves on the board of directors at the Gray Center of Maternal and Women's Health, is also a subject matter expert for the Dementia Care Resources Initiative through the National Partnership for Healthcare and a Hospice Innovation, and a nominee of the 2023 Women to Watch of the Chesapeake. Lauren, I'll hand it off to you.
Thank you, Lauren, for that introduction. Good afternoon, everyone. We are so glad that you could join us for today's program. We would like to remind everyone that in order to obtain your certificate of completion today, you must complete the survey that will be featured at the end of the presentation. I would like to share with you the disclosures for those who are receiving continuing education credits. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accredited Council for Continuing Medical Education through the joint providership of Tidal Health Peninsula Regional and Coastal Hospice. Tidal Health Peninsula Regional is accredited by MedChi, the Maryland State Medical Society, to provide continuing medical education for physicians. The medical education team of Tidal Health Peninsula Regional designates this live activity. Physicians should claim only the credit that commensurates with the extent of their participation in the activity. The planners, speakers, and education team of this activity declare they have no relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Tidal Health is approved as a provider of nursing continuing professional development by the Maryland Nurses Association and accredited approver by the American Nurses Credentialing Center of Accreditation. To successfully complete this activity and receive full contact hour credit, you must attend 100% of the activity, missing no more than 10 minutes, and complete and submit the evaluation. There are no relevant financial relationships. Tidal Health Peninsula Regional is authorized by the Board of Social Work Examiners in Maryland to sponsor social work continuing education learning activities and maintains full responsibility for this program. This training qualifies for one Category 1 continuing education unit. I am pleased today to welcome our presenter, Ann Lovely. Welcome, Ann.
Thank you.
Ann Lovely has over 24 years of hospice experience. She holds a bachelor's degree in nursing and is a certified hospice and palliative care nurse. She has held diverse positions in hospice care, focusing in case management and education, and is currently the Chief Clinical Officer at Coastal Hospice. So happy to have you with us today, Ann.
Thank you, Lauren. I'm so thankful to be able to be here. I'm sorry, go ahead.
I was going to say, what are we talking about today, Ann?
Well, I'm so thankful to be able to be here today to present on in November, which is also Hospice and Palliative Care Month. And we want to talk about the hospice journey of end of life to kind of make sure that everyone knows that it's not exactly like how it is in the movies. So we're hoping that everyone gains a better understanding of hospice care. We're going to talk about the signs and symptoms associated with end of life. And we hope that we can identify ways to effectively educate families and patients about the dying process.
And for those who may not be familiar with hospice, can you explain what is hospice care?
So when we think of hospice care, we sometimes need to think about quality of life rather than quantity. We need to think about what the patient's goals are. Sometimes whenever someone wishes to continue with therapy, sometimes that can interfere with the quality of life. So it's comfort rather than curative to be in hospice care. And one of the myths is that, hospice care means that you have cancer. And to be a hospice patient, it's more than cancer. As a matter of fact, I would say that cardiac is probably one of the highest of the diagnosis that we treat with patients. And also hospice allows patients who are still a full code to be in our care. So it doesn't mean that you have to have a DNR to be in hospice care.
I'm happy that you're dispelling these myths, Anne, because those are things I hear from the community a lot, that they think that someone has to be, have cancer or be bedbound even, or have only a few days left to live. So I'm really happy that we're talking about this today to help hopefully make people feel more comfortable.
Right.
So how does someone qualify for hospice care?
So to qualify for Medicare Part A, you would use your Medicare Part A benefit, and to qualify, you would need the hospice physician and a community doctor to certify that you are terminally ill, meaning that you have a life expectancy of 6 months or less, and that's if the disease follows its normal progression. Also, because it is a benefit, the patient would accept comfort care instead of curative care for their life-limiting disease. And they would also just choose the benefit. So they would just kind of sign to say that they wish to be in our program.
I'm glad we're discussing this more today, because I know we're going to talk more about what hospice covers and learn more, because I don't think people always know kind of how much services that hospice provides. So let's talk about that next.
Yeah, so hospice does cover quite a bit. And I mentioned earlier about our hospice physician and our community physician. So to be in hospice care does not mean that you need to give up your community physicians, as long as they are willing to continue to follow your care while in hospice services. We would prefer that they stay in contact with knowing what's going on with your care, because they know you best. So you would be able to continue to have your community physician, and you would also have hospice physician and nurse practitioners overseeing your care as well. With nursing, we have registered nurses that would come at least every 14 days. We like for our patients to be seen more frequently, so that we can see what's going on, see changes, and being able to teach families how to care for their loved ones when changes do occur. Something else that's covered under the hospice benefit is DME, and DME is durable medical equipment such as walkers, hospital beds, things like that. But we also cover any kind of bandages, any kind of supplies that you may need for your care, such as catheters, etc. Another great benefit is that any medications that are related to the disease progress, the hospice diagnosis, or symptoms would be covered under the benefit. And something that our families really like is when our certified nursing assistants can come out and assist them. They assist them with anything from coming out to chat with them and assist them with maybe back rub, or to maybe even help with bathing and some light housekeeping duties. We also have social workers who come out and assist the patients with community resources. They also may assist them with how to get other resources that will help them, and they may help them with signing of advance directives. And then we also have our spiritual counselors who come out to assist. They may also try to keep their spiritual counselors in the community involved, as well as grief counseling for anyone who would need that earlier. We also have inpatient respite care, and I'll talk about that a little bit more, but that respite care is to give caregivers a break. And we also have volunteers that come to patients' homes to give caregivers breaks and sit with patients. They may read to them, they may run errands for them, all kinds of chores. And we also have music therapists, and the music therapists, it's a joy to see that. Sometimes we have people that may be nonverbal, that kind of remember music therapists. They might be someone with dementia. They might remember the music that the therapist is providing and sing along. It's always a joy to see that.
Absolutely, absolutely. There's so many incredible services that are available with
There
hospice.
is. There really is. And that's why we want to get people on earlier so that they can take advantage of all of these services.
Absolutely. And I noticed that you used the word benefit several times in this, and it really is. Hospice is a benefit. You wouldn't forfeit your Social Security benefits, so why not utilize what we pay into?
That's absolutely right.
So, Anne, what are the levels of care in hospice?
So routine home care is one of the most 90% of our patients are routine home care. And this is when we visit the home to provide symptom management, check on the patients, and improve their quality of life. It could be provided within their private residence. We also provide care in nursing homes. We do have contracts with all of the nursing homes in this area, and also assisted living facilities. So we wherever the patient calls home, we provide the routine home care services. We also have the respite care that I spoke of. This is a benefit through Medicare, where patients are allowed to stay in one of our hospice inpatient facilities or any of the nursing homes that we have a contract with. It's 5 overnights, and it's a great benefit for caregivers who they're able to kind of replenish themselves and be able to care for their loved one whenever they return back home. The other thing is general inpatient. We have general inpatient stay for short symptom crisis care. It's kind of like our emergency department, if you think about it. So a patient who is having a new symptom that we're not able to control at home, we can transfer them to either of our facilities, because we do have general inpatient now at Coastal Hospice at the Lake, which is in Salisbury, and we also have it at the Stansel House, which is in Ocean Pines. And our goal is to treat the patient's symptoms and then allow them to be able to return home.
I think some people will be surprised to hear, Anne, that 90% of our patients actually reside in their homes.
They do. They really do.
That's amazing. I hear a lot that people think, oh, hospice is a place, I don't want to go anywhere. But really, yeah, just to hear that most of the care is provided at home, I think is incredible.
It is.
And so many different options based on what the patient is dealing with at the time.
Yeah.
And do you ever have patients who come off hospice services once they have been admitted?
We do. About 1% of our patient population, because we're giving them that extra care, because they are having someone who's monitoring them so closely. There are guidelines that Medicare gives us that keep someone on hospice services under the benefit. And sometimes we care for the patient and we get them out of a crisis. And sometimes they do what we say, graduate from hospice services, and they're available to, if they need us in the future, we will take them back on then.
How wonderful. How wonderful. Yeah. And what are the goals of hospice care?
So our goal is to normalize the dying process. As I was mentioning earlier, we want to make this not be how it is in the movies. Sorry, my light went out. We want to make sure that it's not like in the movies. We want to make sure that we normalize the dying process, and we want to validate, and then we want to reassure the family and the caregiver in this time. We only have one time to get it right, and we want to make sure that it's a good process for all involved. And Dame Cicely Saunders says, how people die remains in the memories of those who live on. And that's exactly how Coastal Hospice feels.
What a powerful quote, for sure.
Yeah.
For sure. And that's a good segue into our next slide, and let's talk about death and dying.
Yeah. So one of the first things that I do before talking either to caregivers or to even employees about the death and dying process is I ask them their comfort level. Because knowing how they feel about talking about it helps me to be able to talk to them easier. I don't want to take away someone's faith, and I want to make sure that they truly have a good understanding. So I'll ask them, are they comfortable? Are they neutral? Or they're not comfortable at all? And it helps me to have those conversations. And the earlier that we're having these conversations, the better, because it does improve that level of comfort as the time gets closer.
Absolutely. So important for us to gain a good understanding of how comfortable someone is and then go from there.
Yes. Yeah.
Let's dig deeper into what we may see when someone is getting closer to death.
So there are two phases in the dying process. And the first phase is what we call the transitional phase. And that usually lasts about 2 weeks on average. It can be different for anyone. And then there's also the active dying phase, and that's usually right at the end, usually about 3 hours. But there are exceptions to every rule. Sometimes people can go through these phases very quickly, or maybe they might be just a little bit longer. But usually they go through these phases, and because we are visiting frequently, we can help the family know where their loved one is.
So tell us more about the signs that we might expect during the transitional phase of dying.
So during the transitional phase, you often you notice some physical changes. And I think the one that is the most troublesome to family members is when there's a decrease in intake of food and fluids. Because we are from a culture that we feel like that we need to give someone, here, eat this, it'll make you better kind of thing. And what we need to remember is that someone who is in this journey and is transitioning, their body doesn't need food for energy as much as it once did, or they may not require as much food or fluid as they once did. And this person also can become more easily fatigued, and maybe some muscle weakening. So, I encourage families to help them with whatever it is they need help with, like with performing activities of daily living or just regular routine activity. They may require a little more assistance, and that might be when you may want to request one of our aides to assist, one of our CNAs to assist. But these are the most difficult because as family members, we can see this. We can see that they're not eating, and we can see that they're just kind of more tired, more fatigued.
Yeah, you're so right, Anne. The food is really a struggle. We see food as a sign of comfort and as a kind gesture, as a symbol of love, and so to watch someone not eat, it's definitely a difficult time.
Yeah, it is.
What other signs during the transitional phase might we see?
So we might notice that they might be unsettled. They might be talking about things that they want to kind of do. They have some unfinished business, maybe some loose ends to tie up. And sometimes we have to help them with those. Maybe they're not physically able to do those things anymore. So we might need to do that so that they are able to kind of continue on their journey. We also might see physical changes such as edema, where someone who didn't have it before, they might be unable to heal or recover from wounds or infections that they may have once been able to. And this sometimes may be because they're not eating as much protein as they used to. So sometimes, we may see wounds. So we make sure that we're telling caregivers, if you notice that your loved one is laying in bed more, or maybe they are losing some weight to watch out for wounds. And they may start talking to people that we don't see, people that may have already died. And sometimes in the transitional phase, this can be a little more comforting to people. And so, you might want to talk to them about it. If you don't understand, I've encouraged caregivers in the past to maybe even write it down when their loved one is talking to someone, because it might not make sense to you now, but it might make sense to you later. But they also, our medical director, Dr. Juarez, he talks about journey talk. The patient might start using symbolic language such as that they're going home, or that they need to rest, or maybe even saying about leaving. Sometimes that may be symbolic of the end being near. And sometimes with people who maybe English isn't their second language, they may even revert back to their primary language. And that's when we might need someone to help with interpretation. Mm-hmm.
I love your idea, Anne, of writing down what a loved one might be saying or talking about as a way to kind of be able to look back and maybe have a better idea and understanding of what they were they were saying.
Right. And usually as caregivers, we're not as stressed, and we can kind of get a better understanding of what they were saying to us.
Absolutely. So what about the signs of withdrawing?
So some of the things that you might notice is that they're not able to, their attention span is a little decreased. They're not able to kind of keep up with conversations maybe as well as they used to. You might notice that some of their favorite TV shows, they're not really paying attention to anymore. One of the teaching tools that we use the most by Barbara Carnes is When Death is Near, and it is Gone From My Sight. And what we use in that mostly is it kind of describes that decreased attention span as someone who maybe enjoyed spending time reading the newspaper every day. Maybe they're no longer wishing to read the newspaper, or maybe they can't follow along with it. They might also begin to socially withdraw, and they may even start to decline visits from friends and neighbors. And this is kind of hard for us wanting to see our loved ones, and they're just not really up to visitors anymore. And they may even begin to start doing some life review. And this also may be some things that you want to write down, because you might not remember, but this is the time when you want to, when they're still awake and alert, this is when you want to really listen to what they have to say, but also you tell them everything you want them to hear.
Absolutely. I'm glad you brought up Gone From My Sight. It is a great resource. We have copies at Coastal Hospice. We would love to share with you. If anybody would like a copy, please email us or call us and we'll be glad to send one out. How about restlessness, Anne?
Sometimes they can begin to get restless. They may even start to have some confusion, some agitation. You might notice that they're kind of unable to stay still. And it's kind of, this is sometimes when it gets a little more exhausting for family and caregivers. You may even notice that they're picking at their sheets or clothing. And it just kind of sometimes might not make sense to us, but it may be something. Also in the Gone From My Sight book, it also talks about sometimes it's that they're in between here and there. So maybe the fidgeting isn't even recognized to be something that they're doing here. So maybe we're kind of watching it happen elsewhere.
Pain can really be something that concerns people, of course, when we talk about death and dying.
Yeah. So with pain, even people who may have never had pain before, they may start to experience some pain, and maybe it's because they're not as mobile. Maybe it's, because we're able to see the pain. Maybe they were being stoic before, and we're able to see it just by the cues. So, yeah. So some of the medications that we do for pain are usually like a round the clock dosing, or it's a breakthrough pain. And we do prefer to treat with a long-acting pain medication. You know, sometimes there's such myths about morphine and fear to use morphine, but really, truly, morphine is a short-acting medication, and we really would prefer to use for someone who's having pain so that they're not having spikes in pain. We would rather use a long-acting pain medication so that we don't have to frequently dose them and keep them at a steady pace with their pain. But we also have some non-pharmacological methods that we treat pain, because it may be someone who, you know, we're wondering, is this physical pain or is it emotional pain? So we would use a non-pharmacological method, such as breathing exercises. We might use guided imagery, any kind of distraction. And I have to tell you, with pain, sometimes if you're just not thinking about your pain and you take something for your pain, distraction can allow it to work before then. Also, massage can help if they can tolerate touch. Sometimes when people are in pain, they don't want to be touched. And also maybe counseling, but not forgetting about the you know, hot or cold compress that may help. And then prayer, that sometimes gives peace.
Hearing this,
I did see,
yeah, you see the chat box. Yeah.
I did see the message about what if they're allergic to morphine. So we would use what has worked best for them in the past. For a long acting, we typically use methadone, but we would work with the patient to see what has worked in the past if they're allergic to morphine.
That's very, very helpful to know. Great question from the chat. Please feel free to chime in to the chat anytime you have a question, and we'll certainly answer. I think hearing the non-pharmacological approaches is really interesting too. And, you know, people often think about hospice as, you know, medication, but there's so
Right.
many other things to do.
Right.
Thank you, Paul.
Mhm.
What signs and symptoms of pain might we see?
So sometimes you may see someone may just tell you that they're having pain, but we also have to think about like how they describe pain. But sometimes you have to look for those visual cues, such as facial grimacing. They may be guarding the area. They might be kind of holding their back or holding an area as they're turning in bed or walking. Also, listen for the groans. If you know they're crying, kind of pay attention to that. Also, they may show signs of pain by becoming agitated or restless. So you kind of want to look out for that as well. And maybe they're shuffling instead of walking as they used to do.
It may not be as simple as just someone letting us know, hey, I'm in pain. Got to look out for these things.
Right.
Why might patients be at risk for lack of treatment?
So there's many reasons. But one I can think of is age sometimes. You know, if a patient is too young and unable to tell us, or maybe they're older and naive to medication, maybe we don't want to give them medication. Also thinking about nonverbal or someone who speaks another language. Sometimes with nonverbal patients, or maybe someone who can't tell us, we might just order Tylenol for them a couple times a day, just to see if that can kind of keep the edge off and see if that helps with some of that agitation and fidgeting that I was talking about earlier. Also, people may fear addiction. I've had people tell me I'm fearful it won't work when I need it to. And really, truly, we are experts at pain control. We do a great job at making sure we titrate medications appropriately. I don't want that to be a fear, but sometimes there are folks that do have addiction issues. And we have pharmacy consultants and we work well with those, because sometimes they require a little bit more medication, or maybe their fears So we work with our pharmacy consultants a little more for people like that. But also there's a fear of giving the last dose. And that can be difficult, but really truly that's not our intention, to give someone medication with the idea of taking life. So instead of being fearful of giving the last dose, I like to think of it as that we're giving a patient medication that's going to make them comfortable. And if that allows them to pass on, it wasn't necessarily the medication that did it, that it was the comfort that allowed them to go on.
Absolutely. And that's a great way of looking at it, describing. I did see another question from the chat box. It says, what would you do in the case of someone being younger or older, like the age situation?
Mhm.
If it's
Sometimes we just go ahead and give someone a scheduled dose of medication, and it might be as low as Tylenol, or we may kind of titrate up to different medications.
great. Thank you, Anne.
Mhm.
This was a really eye-opening look at the transition phase. I think it was super helpful to see. Let's move on to the active dying phase.
So the active dying phase, remember, it can be sometime around 3 days before life, or the end of life. And the inability to arouse the patient is one of the first things that you'll see. They may kind of go into a coma, or like a unresponsive semi-coma type state. You might notice, even though they're that way, the little bit of agitation that it may be increased. They may have some increased hallucinations. So maybe some of these symptoms that they were having in the transitional phase they may now require medication. And sometimes we may give a little bit of lorazepam for these symptoms, or we may even give low dose Haldol, which works wonders for people at end of life.
How about breathing changes?
Sometimes we'll see breathing changes, which you'll see pauses, and those pauses it's called apnea. Sometimes they can be, sometimes it can last anywhere from a few seconds to very long periods. And usually in the active dying phase, you do notice this. One of the things that I like to do with a patient who is in the active dying phase is to teach the families about the changes that they're going to notice with breathing. It can go from very fast to very shallow, and I like to warn them, because this may cause them to have if you warn the family, it causes them to have less anxiety about the changes that they may be seeing. Sometimes oxygen helps, but not often. It's just kind of the pattern where they are in their breathing changes.
That's helpful to know, because I'm sure it can be alarming if you don't know to expect this. And then you
Right,
see
right.
happening. I have another question from the chat box, Anne. It says, do you work with individuals that have been diagnosed with Alzheimer's and/or dementia?
I'm sorry, can you repeat it?
Sure. Do you work with individuals that have been diagnosed with Alzheimer's and/or dementia?
Yes, and we do have patients that have dementia, Alzheimer's, dementia, and working with them, we like to get them a little bit, we usually get them a little bit earlier, and working with them, we can medicate them if they have any pain, and usually working with the other services that we have, involving them, because working with someone with Alzheimer's, it can be overwhelming for the caregiver. So we often give people assistance with respite with people who have Alzheimer's. We also aid services. Music therapy is one of the best things that I've seen with Alzheimer's patients, and so yes, we have quite a few of those patients.
I agree about the music therapy. And in my previous life, I was the director of a dementia unit, and my patients loved when the hospice
Yes.
music therapist came out and sang with them. And I had actually one patient that I can think of that she didn't talk anymore. She wasn't talking anymore. She was nonverbal. However, when Chaplain Joel came in and would sing with her, she would sing the words and she would know all
Yes.
the words. And
Yes.
everyone, you just couldn't, everyone would just cry about it. It was
Yes.
beautiful. And
Yes.
what a gift to the family too. Once we saw this happening, we called the family to let them know because we wanted them to be there the next time, and they were, and it was such a gift. Yes.
It is. It really is a gift.
It is. So Paula, also, I just want to let you know, we worked with the National Palliative and Hospice Initiative and created a patient and caregiver guide that I was able to co-author. So we have copies of that. I'd love to send you one if you want to email us. I can certainly send it to you, or it's on our website and you can look at you can just download it right from our website. And we'll have a provider guide soon coming out within the next year too. So definitely utilize those resources if you have some patients that you work with there. Awesome questions. Thank you so much. Thank you. What about, I know there's some more breathing changes that we were going to chat about too, Ian. What do we have there?
So sometimes people in the active dying phase have an inability to swallow. And so it makes it difficult to swallow. So you don't really want to offer them food or fluids if they're not awake and alert and able to swallow. And that is difficult for folks. As I was talking earlier about the food, we want to make sure that they're awake and alert so that they don't aspirate and the fluid go into their lungs. So as difficult as it is, we have to remember that they don't have that need for food as they did when they're in the active dying phase. That is a difficult part. So we make sure that we are providing mouth care. Also, you may start to hear some congestion build up because where they're not able to swallow, sometimes it's kind of stuck in the throat. And I know that some refer to it as the death rattle, but we call it terminal secretions. And it is kind of that noise where they're not really able to get it up and they're really not able to get it down. So what we teach folks is there is some medication that we have that we can offer patients, but it doesn't always work either. So what we talk about is that it's more bothersome to us than it is their loved one. And we encourage them to reposition the patient and see if that helps. And then it's also sometimes they will breathe with their mouth open, and sometimes their neck will kind of get stiff, or they may kind of be doing guppy breathing. So all of this is explained to the caregivers because it's such a variety of breathing changes, and just telling them that it is normal. So that they, don't feel that their loved one is experiencing something different.
Absolutely. So speaking of the food, tell us about artificial nutrition and hydration.
So sometimes some of the dilemmas, families are just so concerned because their loved one is not receiving food or fluid. But what we need to remember is even with artificial nutrition and hydration, people just can't handle as much as they would if they were still healthy. And so some of the issues that you may see is that with tube feedings, they still aren't able to absorb that food. So it may still be in their stomach and unable to kind of accept more feeding. So we would need to be careful with how much food we are, we usually typically back off of tube feedings anyway. It's a very high risk with someone who has tube feeding that they are going to aspirate. We have to make sure that their head of their bed is elevated really high, and just be very careful. So artificial nutrition and hydration isn't always the best choice at end of life. Also with IVs, the body just isn't absorbing those fluids as they once were. The kidneys are starting to shut down, and you can actually see that swelling. They're holding on to that fluid, and it may cause increased swelling kind of all over.
Very helpful.
I'm sorry, and also, and death, what I'm told is death is not as painful if the patient is dehydrated versus if they have a lot of fluids on board.
Mhm. I think this is helpful, Anne, because I know this is something that a lot of people get questioned about from patients and from family members about this situation. So having this to be able to share with them, I think is going to be super helpful.
Right. This is one of the hardest topics, I think, whenever we're talking with our families.
I'm sure.
Yeah.
Absolutely. How about extremity changes?
So some of the things with someone who is usually very close to the end is that you'll start to see cyanosis or like a bluish purple tinge of around the arms, legs, maybe even around the lips or nail beds. We also may call it mottling. It's like a bluish purple color, splotchy color. Like usually the lower extremities, we see this. We also they may be cold to touch. It may be someone who was always hot, and we may notice that their extremities are now cool to touch.
Mhm, mhm.
Yeah.
We talked a little bit about the decrease, or actually, first let's talk about changes in vital signs. What changes in vital signs might we see?
So sometimes when people are in the active dying phase, they're unable to kind of regulate their own body temperature. So it may be that they are hotter, or it may mean that they are colder, they're more cold to touch. So they may have increased perspiration, or they may even feel clammy. So sometimes we have to kind of change. Sometimes we have to change our vitals, and we may have taken vital signs all the time, and we might encourage families to maybe not do their vitals as often as they may, because sometimes they just fluctuate so much that it's more bothersome to us than what it is. And sometimes we don't worry about the numbers, we kind of treat what's going on with the patient.
Sure, sure. Have another question from the chat box, Anne, and this question is from Juliet.
Mhm.
Says this question is from an earlier topic. I am a hospitalist and thought that patients had to be a DNR to enter hospice. Can you please give an example of someone who's a full code but could enter hospice? Also, can patients on hospice still go to the hospital for acute issues like infection? Thank you.
So it is really the patient's choice whether or not they continue to go to the hospital once, with the most. The most they can determine, if they had an acute infection, if that's how they would want it to be treated. So it truly is up to the patient. Our goal is, and Medicare's goal is for the patient to, if they're receiving our service, to allow us to treat them. And for someone who is a DNR, or I'm sorry, a full code, we accept them onto our services because we feel with our education and with the progression of the disease that we can show them and their families that this is normal disease progression. We talk to them about the patients, unfortunately, even if they were to get CPR, that unfortunately they're still going to have the same illness. And it's inevitably going to happen. So we kind of talk to them about how we're going to keep them comfortable and how that we're going to make this as peaceful as possible, instead of going to the ER and possibly receiving resuscitation. And again, as I said earlier, it's just not what it's like on TV. And I hope that answered your question.
Very true. I think it's important to note too, there's so many things that we actually can treat at
Right.
home and take
Right.
care of the patients at home or a nursing home or wherever
Yeah.
the case may be.
Yeah, and if we can't treat them there, we do have our inpatient facilities that we can send them to. But sometimes families panic and
Mhm.
they, they're more familiar with the hospital. So, there's those situations too. And usually we're able to go see our patients and get them into one of our facilities or get them home with the care that they prefer.
Absolutely, absolutely. And we are available 24/7. So patients and families can call at 2 a.m. and we'll, be available to them.
Right.
So thank you, Juliet. So we talked a little bit, Anne, about decrease in output. Can we see what other changes in output that we might expect?
So someone who, was able to care for themselves and get up to go to the bathroom, they're now bedbound in the active dying phase. So we have to remember to teach patients and we have to remember to teach caregivers that this person may now even be incontinent. Sometimes we give Foley catheters to patients, but we do want to be careful with infection. We don't want to increase that risk. But they also may have a change in their actual output, and that's because they're not getting as much fluids, and so their muscle wasting, and the color of their urine may be red or brownish, and also because their kidneys have begun to shut down, there may not be fluid. So sometimes giving someone a Foley catheter isn't always the answer if the kidneys aren't working well enough to produce urine.
Thank you, Anne. I had a chime in from the chat box from Lori. Hi, Lori. She says, hi, this is great info. Will these slides be available so I could share with my staff at the nursing home? Yes, absolutely. We will send out the slides after.
Sure, or we'll come talk to them.
We will. We absolutely will, Lori. We were with you not
Yeah.
long ago, I know, but we will come right back. We would be
Yeah.
happy to do that. Anyone on this that would like us to come speak and give this presentation to your staff, we would love to do that. So please certainly let us know. We can do that, but we will be sharing the slides too. Thank you, Lori. How about that surge of energy that some of us have heard about? I know.
So surge of energy or burst of energy, it can be a blessing. It is usually for someone who is it's the active dying phase, and it's just this sudden unexplained surge of energy that happens. And it's usually days before someone passes, and it can be as subtle as someone who had their eyes closed and was kind of comatose, and they just simply open their eyes, or it could be someone who wasn't alert and all of a sudden they're sitting themselves up on the side of the bed and asking for food and communicating with their family again. It can last for a very short time, or it can last for a little bit longer, but it is a blessing, and sometimes it can begin to make people think that maybe we got it wrong, but it is a blessing, and I love to hear the stories that families experience with the surge or the burst of energy.
That is so helpful to know, because I think if you're not aware of it, like you said, Anne, you might think, oh, they're getting better, they're gonna, they're doing okay. But really, if we look at it as this is a gift, this is a gift that we get a little bit more time with them alert and clear.
Right.
Yeah. Any additional changes that we should be aware of during this time?
Again, they may no longer be able to, with them at the very end, this is usually at the very end, they may lose muscle control of their jaw. They may not be able to kind of hold themselves up. Sometimes their face can even look a little twisted. Their eyes, because they can't blink, they may stay open. They might kind of dry out a little bit. So sometimes we just kind of talk about people gently wiping the face with a damp cloth, and their body might even get a little stiff. And I kind of talked about earlier about where their mouth is open, breathing. Sometimes their neck is a little hyperflexed. Yeah. And usually at this point, we're letting people know that death is very near.
So what can we expect once death has occurred?
So, when death has occurred, we'll notice that we won't see respirations. We won't feel a pulse. Their eyelids are usually open, and with their pupils fixed. And we said that their jaw was a little tight and sometimes it does relax. But you can also notify the nurse, and the nurse's presence will be there. And we're going to make sure that you have the family there. While we are, we will confirm death and notify the physician. We'll encourage family to come to visit whoever wants to come. And then once the nurse is there and has confirmed, we would notify the nursing home. I'm sorry, the funeral home.
And what about support, bereavement support and aftercare? What's available?
So our bereavement support is wonderful. We have all types of bereavement support to offer. One being is we have bereavement counselors. Our staff sends cards. We have telephone calls. We support the caregivers that are left behind for 13 months to get everyone through the first of everything, including the anniversary of the patient's passing. We have all types of support for children. We have in-person visits. We have telephone calls, whatever it is that you prefer. And then we have group counseling visits also. But we really want to make sure that our bereaved are taken care of and that they have what they need to continue on.
Absolutely. Absolutely. This is a difficult conversation to discuss, but it's really, it is difficult, but it's comforting to know that there's so many resources available and so much support is available both before and after someone passes.
Absolutely.
And this was so informative, very helpful. Questions from the audience were amazing. So I just want to thank you for being here with us today, Anne.
Thank you.
And Lauren, I'll turn it over to you.
Thank you, Anne Lovely, for this presentation on a topic that may be relevant for many. And thank you to everyone who has joined us today. We hope the information was useful to you. We encourage everyone to attend, to visit our website to see our upcoming Caregiver Academy programs for next year, 2024. Our next webinar is scheduled for Tuesday, January 23rd at 12 o'clock on a topic, deprescribing and advanced illness. Please visit the website soon to register. To wrap things up, we ask that you take a couple of minutes to fill out a short survey. By filling out this survey, you will allow us to provide you with your continuing education credits to your via email, and feedback will help us bring relevant programs to you, your practice, and those you care for. To complete the survey, visit the chat box. You will need to click the appropriate link for your field or scan the QR code on the screen now. You will be able to print your certificate of completion immediately after completing the survey. Additionally, you will receive a follow-up email later today containing the links to the surveys. Please remember that you will need to fill out the survey within 24 hours in order to receive the continuing education credits. This was a presentation from the Coastal Caregiver Academy, supporting and empowering caregivers in our community. At Coastal Hospice, we are here for you, and you can call us at any time on the number on your screen. Thank you once again for joining us. I am Lauren King, and have a wonderful rest of your day.